So I continue now with my next lecture, and I must give a special thanks to Liliana Warner, who contributed with some of these slides. And why the title Presbyopic Refractive Surgery 2004 and 2009? The fairy tale continues. This is actually a presentation done in 2004. It's fairly obvious that we have seen changing demographics all over the world. In my country, Sweden, people get older and older and require more and more help, both for reading and for what have you not. The benefits of, for example, multifocal IOLs are that unlike multifocal contact lenses, the IOL is positioned extremely close to the eye, nodal point, and it can be well positioned with little to no movement and do not suffer from protein or other debris accumulation on the lens. The disadvantages of multifocal lenses are huge. We have an image degradation from loss in contrast sensitivity. This is due to one image being in focus, juxtaposed against an out-of-focus background image. Further similar to our experiences with multifocal contact lenses, the image in focus is then more readily compromised by astigmatism, lens tilt, capsular opacities, pupil dilation, and subclinical cystoid macular edema. In addition, diffractive optics may be associated with more chromatic aberration, astigmatism, and coma than monofocal intraocular lenses. We talked about this before. Patient selection is one of the keys to success. The patient, as has been stated before, must be able to adapt to glare and halos. These are common even with conventional IOLs. There are slightly higher levels with multifocal IOLs. And making your patient aware before surgery of the possibility for glare and halos minimizes the shock factor should they in fact notice them. It has been demonstrated a binocular summation effect with quality of vision studies showing improved patient comfort once the second eye is implanted. Immediate post-operative healing and the effect of visual acuity is, I don't think it worked. You will hear that ever so often. But you have to tell the patient here, be patient, because this is a healing process. It's a process that also involves your brain. What cannot be emphasized enough in these patients is the ocular surface. The ocular surface disease or the syndrome or a dry eye is certainly having a great impact on vision with either multifocal lenses or if you do a corneal ablation procedure. The pearls of patient selection, patient psychology, low concern for perfect contrast vision, slight tolerance for unwanted visual phenomena such as halos, good personality, those who desire perfect distance vision are less suitable, pupil size matters, and 1 week between the two surgeries. We've talked about presbyopia before, and I will just give you some examples of what we can do to correct the cornea for observed accommodation. We can use ATR's astigmatism, Cernica vertical coma, cernica aspheric aberrations, prolate cornea, all these will increase the depth of focus. Or we could do a multifocal cornea. Others are like hyperpositive intracorneal implants or pinhole inlays. The examples of intraocular pseudoaccommodative lenses are multifocal IOLs, high IOL asphericity, IOL axial meridian displacement, and maybe there are others. This list, made 5 years ago, still holds very well. And I'm not going to go through it in detail, just to have some small comments on scleral ciliary surgery. We are not using that anymore. The results have been controversial, and if you try to get hold of some results out in the world, it's almost impossible to get hold of them. Corneal excimer laser surgery, certainly probably the most exciting of the laser or corneal ablation procedures, because you can create so much with it. The results so far are a little bit contradictory. We are inducing corneal aberrations, and we are claiming to restore up to 1.5 diopter of amplitude of accommodation with that one. The techniques, the one that I prefer is the Chobard technique with a super prolate cornea. Visex have an aspherical treatment designed which seems to work fairly well. And moving on to the corneal inlays, while we are on the cornea, we need a laser cut and a corneal inlay placement. There are very few results reported on this, and what it does really do is to increase the depth of focus, nothing else. However, from the experience in Alicante were that a lot of these inlays were taken out or removed because they did not work, or cosmetic reasons, because you will see this inlay on the cornea. I will move on now to intraocular multifocal lenses. And the aim here is, of course, to mimic accommodation through lens multifocality, whether it's diffractive, refractive, or hybrid. So we have a lot to choose from there. And with the results here, they claim to restore up to about 2.5 diopters of amplitude of accommodation. It's doubtful, however. We have a big choice of lenses. This is the multifocal refractive from Array and AMO. We have the Acritech from Twinset, Germany. And we have the Acquisoft Restore, which is not really a true multifocal. I would rather call it a bifocal lens. We have the Technis Z-Zoom lens, which is a diffractive lens. And we have the Rezoom, also from AMO, which is a refractive lens. So, the intraocular lenses that are positional and accommodative. Here, again, we are trying to restore accommodation. But it requires an active ciliary muscle, elastic lens capsule, and the vitreous plays a certain role. Again, about 1.25 diopters of amplitude of accommodation can be restored. Examples is the crystal lens, human optics, smart foil lenses. They are looking into this in the United States, and this could be something for the future. The results are very strange at the moment, but it is dependent on a very interesting factor, namely the body temperature. And it could mean that this lens, the Smart IOL, might be something for the future, but as I said, we are still in the beginning of the trials with this one. The injectable lenses we have not seen too much of so far, where you inject a silicone polymer into the bag, and this was published by Nishi in 2008, and we're still waiting for his results to be more, or that will be more results on this interesting lens. What is even more interesting is the light adjustable lens that I like to spend just a little bit of time on. This lens is a monofocal lens. You can perform your natural procedure when it comes to cataract extraction or lens procedure, whatever you like. And you don't need to worry too much if you missed out a little bit on the power, because the power of this lens can be adjusted by exposing it to UV radiation. That is to say that I, first of all, can adjust the spherical power and the cylindrical power. When I've done that, I let the lens rest in the eye for a week or so. After that, we can redo it before we are locking the position, and I can contrast something like the restore lens configuration to achieve reading abilities. And this certainly is a great challenge, and it's very, very exciting, and we've been working with it now for 2 years. So changing the anterior surface with the accommodating lens, new lens, we've been waiting for this lens for many years now. It's been rumored around 5 years, and we're still hoping to see some results of it. However, it claims to be able to restore about 8 diopters or even more of accommodation. We have the Acco lens. That's also an accommodating lens from Breda in Holland. Also very, very interesting concept, where the lens is sliding, where you have the elements sliding over each other, and by that changing the power of the lens. And this could be a very, very exciting and thrilling thing to work on as well. Work is still going on with rabbit eyes on this one. Synchrony lens, we don't know too much about, from Visogen in Irvine. It's a one-piece silicone lens, and we hope to hear more about it in due time. So, the concern with the dual optic lenses, all of them, is the interlenticular opacification. And Liliana Warner has written a paper published about this in American Journal of Ophthalmology as early as 2002. And the investigations of this occurrence, or this opacification, is still ongoing.